Good afternoon, everyone, and thank you for joining me today. My name is Jim Pavlik, and I'm the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. We are the statewide provider for technical assistance, and today we are in the third webinar in our Tobacco Cessation Justice series. And I want to start this third and final webinar where I began the first one, which is with an unequivocal endorsement of the CDC statement that the best tobacco program is a comprehensive one. An effective and efficient public health policy regime should include price controls, including both taxes and price floors, point of sale regulations, marketing restrictions, secondhand smoke protections via clean indoor and outdoor spaces, density restrictions, product warning labels, including graphic ones, the whole nine yards, everything I just said and more. The purpose of a robust, comprehensive regime prevents people from starting to use tobacco products by making them less available and by making them more costly. These same availability and cost controls also change the decision landscape, making quitting a current habit more desirable, and for some people, switching their decision from one of continuing to use to one of attempting to quit. And these same changes also make relapse less likely for the same reason. High prices, the effort involved in going to stores that are further away, removing enticing marketing materials, making rebates less effective, also provide the rationale for an endless stream of public discourse aimed at changing the acceptance of tobacco use as a part of regular participation in society. Even in my own lifetime, the status of smoking has shifted dramatically from one of a default position of acceptance to one where the default position is one of rejection. It is impossible to understate the importance of this cultural shift in driving down prevalence rates and keeping them low. But I also want to reiterate that while all these things are important, critically important, that's just not what I'm talking about in these webinars. In these webinars, we are talking specifically about interventions that public health can design or collaborate in that increase access to tobacco cessation services, and if accessed, the capacity of those organizations to provide the intensity and type of care to maximize cessation rates to the uppermost level that science has devised so far. And specifically, we want to design systems that can competently address the needs of those individuals who are members of groups that have been specifically targeted by the tobacco industry. Because if we can design systems that are able to address their needs, we will create systems that are well equipped to handle tobacco cessation for everyone. Now, that may not be a claim, the truth of which is immediately obvious. So let me give just one example. One thing we know about Asian American smokers is that they have a disproportionately higher share of individuals who smoke 10 or fewer cigarettes a day, what we would call light smokers, or those that smoke less regularly, what we'd call casual smokers. Now, these two patterns show up in every classification of smoker. And in fact, there are those in the therapeutic spaces who advocate for a type of harm reduction in smoking that involves stepping down, which would mean converting an individual from, say, a heavy or moderate smoker to a quote unquote light smoker. The problem is, as I will repeat later, stepping down doesn't really grant the health benefits that many people believe that it does. So systems that are able to efficiently educate around the risks of light smoking and successfully navigate light smoking patients toward abstinence are going to have a higher or a disproportionate impact in priority populations like Asian Americans with a disproportionately higher share of light smokers. But in fact, they're also going to be better equipped at handling the light smoker in the general population or in other groups. In the previous two webinars, we have done two things. We've established that we need a full appreciation that tobacco use is nicotine-seeking behavior more than anything else. Even if it starts as something else, a focus-enhancing drug, self-medication for depression, an avenue for socialization, cultural esteem, even if it starts off as something else, it will become nicotine-seeking behavior for about a third to a half of regular users. The other thing we did was look at some of the differences in use and dependence in select demographic groups. What we established there is that social cultural norms, tobacco industry attention, and the availability and quality of healthcare are the primary factors that drive prevalence rates and health outcome disparities. And that's not to say that biology and the desire to quit and knowledge of harms or the level of dependency don't matter. It's just that they are not the primary drivers of the prevalence rates and health disparities differences that we see. So today we're going to look at two aspects of tobacco cessation delivery. First, we're going to look at the quality of care and what defines evidence-based treatment. And we're going to make the case that culturally competent, tailored care works. But I don't expect that most of you in attendance today will be cessation service providers. I don't think most of you will sit face-to-face with clients as counselors, therapists, case managers, nurses, or doctors. Some of you may, and I hope that those of you who do will find that material useful in its own right. But the second thing we're going to do is look at some tips for health systems change. And that thing, the second thing, follows from the first. Public health can help organizations in the health neighborhood design systems that support high capacity, evidence-based, tailored care. And it's helpful to know kind of what that tailoring looks like. So that's a lot of ground to cover in a limited amount of time. So I do want to get started. So the first thing that we need to understand before we even look at the culturally tailored component is really what constitutes evidence-based tobacco cessation. And primarily when we're talking about these things, the things listed on this slide are those are the things that are shown to have impact on both increasing quit attempts, increasing the number of successful quits that we would otherwise expect to see in a population without those interventions. So among those evidence-based interventions, we have clinician advice, which is to say that when we compare two groups of people, one group who receives the advice to quit from their doctor versus another group who doesn't, we see that those who receive that advice are twice as likely to quit as those that don't. Next, we see using evidence-based modalities. And the two evidence-based modalities for tobacco cessation are cognitive behavioral therapy and other modalities within the cognitive treatment family, and also motivational interviewing. We also see that we can use those modalities within group or individual sessions. And with individuals counseling, we can apply up to 4 sessions at greater than 10 minutes per session. And we would normally say that they would get 2 quit attempts per year, so a total of 8 sessions over the course of a calendar year. Next, we see psychoeducational groups and then telephonic counseling, which is, of course, our fancy way of saying quit lines. And we see also text messaging and other digital support for motivated adults before moving on to peer support, tailored materials, and, of course, cessation medications, by which we mean nicotine replacement therapy, bupropion, and varenicline. Now, in the orange box, and I always call this out, we see screening, assessment, and education. Now, these are not independently associated with increased cessation attempts, and they don't necessarily lock in cessation attempts. However, they are components of the they are components of the things in green. And as long as they are part of a continuity of care that includes those things in green on the left, then we can say that we're adding to the robust comprehensive health neighborhood. And what's nice about those particular components is that almost anybody can do them, so they're easy to break out and have done separately when we're doing our program design. So speaking of public health, when I think of how public health can most effectively aid in building responsive health systems, I like to think of embedding the evidence-based interventions from the previous slide into a 5 A's framework. So public health can help organizations building their screening process, advising process, and so on. The care delivery organization can determine which of the evidence-based interventions they can or will provide, and they will also determine the character of those interventions, for example, by choosing which modalities they support. And that's all going to be there in that assess and assist area. And then finally, public health can support the arrange piece, by which we mean facilitating partnerships between sites. Excuse me. When we want to drill down to closing health disparities in use, in cessation, or in outcomes, one of the main strategies is helping organizations to understand the need to track their performance and to aim delivery at universality. Everyone should be asked about their tobacco use at every visit. Everyone should be advised to quit and connected to resources that are appropriate to their dependence level and their preferences, which is to say that public health agencies can encourage care delivery sites and practitioners to develop cultural competency and to modify their treatments to fit the needs of their clients. But public health does not have to educate on the specifics of what culturally tailored care looks like necessarily. However, I do want to talk a bit about what we mean by culturally tailored care and what some considerations are for key demographic groups. Because understanding what is being done at the clinical encounter level can help in determining what supports are necessary to sustain that kind of effort. Before going into the next slide, I do want to talk about that phrase evidence-based. And the first thing I want to say is that our evidence base includes certain activities, the ones I just described on the last two slides. This includes all those interventions in green, given a grade of A or B by the United States Preventative Services Task Force, and also the use of the 5 A's to guide tobacco cessation clinical encounter. However, the evidence base also excludes all those interventions and modalities and programs, et cetera, that have failed to achieve consistent results. But what works in the so-called general population may be different than what works in various subpopulations. Or to say that differently, something that works really well and consistently with, let's say, with Chinese Americans, that particular intervention may fail to replicate in other demographic groups or in the population writ large. So I'll bring this up again later, but it bears bringing up now that the things I've just gone over do work everywhere, but tailoring makes them work better, right? And so we just need to be a little bit more conscientious about what we exclude from this category if we find that something works in a group that we are in a population that we are focused on. So the next thing I want to say is that many organizations are already doing well in providing evidence-based treatments, say generally, to the individuals they serve. And other organizations are very good at providing culturally appropriate care that isn't necessarily evidence-based in the way that I just described. So sometimes the task at hand is determining which, if any of these skill sets, your partner agencies already possess. Are you adding something like a 5A structure to a wonderful, culturally appropriate system? Or are you helping culturally tailor and fine-tune a machine so that it gets even better within certain demographic groups? And that brings us to the question, what do we mean when we say that care is culturally tailored? And well, for starters, we need to take a look at our program staff and, to the greatest extent possible, remove as many representative disparities between our staff or your partner agency staff and the people that they hope to serve. We need to diversify our staffs, to use a slightly different phrase. But even if we made sure that our tobacco control staff are ethno-nationally, racially, religiously diverse, et cetera, there are senses in which the employed, typically college-educated public health staff are just going to significantly differ from the communities they serve. These differences may or may not be critical to program success, but we may not know that that's the case until it's too late. So in general, we do want to go to a community. We don't want to go to a community with a solution already in hand. Instead, we want to go to the community seeking to understand their needs and how they want to address those needs. And if our capacity and our charter align on those principles, then we can partner. Then after we partner, and to the greatest extent possible, we want to relinquish control over the execution and administration of the program to that community. Which leads us to the next bullet. If we have successfully listened to the community, we won't be able to stop ourselves from at least trying to be responsive to the community's unique needs. In all cases, materials and the modality of the intervention itself should be responsive to the needs of the community. While community values should be known and articulated, not all tailoring means appealing to the values of a specific cultural group. And that sounds maybe controversial, but let me explain. In one style of intervention that we know works, right? Making an additional outbound phone call using interactive voice technology after African-American smokers had left the quit line, that additional outbound call was able to dramatically increase the amount of individuals who re-enrolled in the quit line. So that's a really effective intervention. And it really did drive re-enrollment rates, but it is not obviously a value-based adjustment to regular service. Connecting smokers to quitline coaches who share their language or understand the norms of a culture has been repeatedly shown to be an effective model because it diminishes the sense that the practitioner, quote, is not like the caller and raises medical trust. And also because using the quit line is something that can be done with more privacy than a trip to a counselor, which can help with communities that have a greater sense of shame surrounding the need for behavioral health care, or have a greater sense of personal failure surrounding their inability to simply walk away from nicotine. These can be really helpful interventions. It can be assumed that practitioners working with individuals need to plug into a patient's values. This sort of contradict what I just said. We do need to plug into values, just not with every single intervention we do. So it's that, and that's important regardless of whether those values have cultural resonance, right? And when working with individuals in a one-on-one setting, that's always possible because we're always exploring with the individual. However, in the design of educational or instructional materials, we have to be aimed a little bit more broadly to the values that are known to be held commonly within groups. In these cases, we will need to rely on those values that are understood to exist, or if you have the resources to perform focus groups, use those that are composed of members of the community that you hope to engage with. And of course, we want to use images and language and overall graphic design that appeals to the groups you're working with. Whenever possible, utilizing members of the community to actually develop or at least help develop those materials. As of 2010, researchers were still saying that research into culturally sensitive interventions was still in its infancy. And that was true then, and it largely remains true now. There are a few limitations that we should note here in terms of why the results are mixed. And one is that the study designs themselves tend to be mixed. Some of the literature on the subject will test all quote unquote culturally tailored interventions within a specific treatment area like tobacco cessation. Some narrow down some, but not all the way. So for example, some researchers might be looking at tobacco cessation interventions for all Asian Americans, while others will focus on Chinese Americans. But even when a group is narrowed down, there's always the risk that regional differences are important. So a qualitative study looking at African Americans in the Arkansas and Mississippi Delta region might not be generalizable to the opinions and thoughts and feelings of African Americans in Colorado about the quit line. There's also the case that what constitutes culturally tailored is variable. And if success and failure of a culturally tailored intervention depends on how well it was tailored for the needs and expectations of a specific group, well, that's a slightly different question than whether quote unquote culturally tailored interventions more broadly work. And of course, this is mostly a very practice-based type of research where blinding is basically impossible. Practitioners are aware if they're providing a culturally tailored intervention or the standard one, and recipients are likely to see and hear culturally tailored images or phrases, even if they aren't able to compare what they're seeing and hearing to the quote unquote standard intervention. What I have found as I've gone through the research myself is that the more specific the review, whether on a single intervention or a set of interventions with a specific treatment goal and with a single narrowly focused group, the results are routinely clear with less mixed results that culturally tailored care works. In Wu, this is a study, Wu et al. 2012, that, for example, focused specifically on culturally tailored motivational interviewing interventions for Chinese Americans. And that study showed that motivational interviewing in that group that was culturally tailored for that group doubled quit rates from 32% in the standard intervention to 67%. In another study, they found that providing the tailored Pathways to Freedom self-help guides to African-American callers to a support line showed that those receiving the tailored materials found them more attractive. And in addition to being more attractive, they found them more trustworthy and more helpful. It led to more quit attempts at 6 months and more use of pre-quitting strategies. And in a 12-month opportunistic follow-up, they found a greater increase in long-term quits as well. In another study, the use of All Nations Breath of Life increased quit rates among Native American and Alaskan Natives by 50%, moving them from roughly 20% to about 30%. So whether researchers are looking at Chinese Americans in the study above or Asian Americans, as in the first study I mentioned, or in African Americans or Native Americans, we all see over and over again that culturally tailored care does in fact work. So how do we do it? And one way that we can start to do it is by incorporating something like the addressing model shown here, developed by Pamela Hayes. And I do want to share it, but I want to share it with the caveat that I hope is, I don't know, peeking through a little bit through some of the stuff I just said. And that's that while knowing what another person's cultural influences are can help us understand that person's behaviors and decisions, that type of knowledge really needs to be taken with a grain of salt, or perhaps several grains of salt. Individuals are just more than the sum of their cultural inputs. And we'll get to this kind of as we go forward. But in the meantime, let me say that I appreciate the addressing model a lot. I know that ADDRESSING is a really long acronym to try and memorize, and I certainly do not have it memorized, but I think its length is part of its usefulness. It's a reminder that the person in front of you is not just Hispanic, not just lesbian, not just a woman, but is a complex person with a lot of overlapping cultural inputs. It's an active reminder of the complexity of an individual's identity, and also acts as a reminder that before drawing any conclusions about the individual, we should be exploring the diversity of their influences and how their unique dimensions reinforce or contradict one another to create that unique individual in front of us. This notion that an individual is an individual is something that I have said and I will continue to say, but it shouldn't be taken to its extreme position either. The fact is that the effects of culture are large and often invisible, but they are real. People are products of their culture. They're just not merely the products of their cultures. So I do want to take a look at some specific groups. And I want to begin with the Asian American population. And the first thing that we need to do here, and I'll say the same thing when we get to the Latinx population, is that we need to consider the nativity status. That is to say, the individual's national, ethnic, or cultural background. And when we look at the group that is called, quote unquote, Asian American, right, we see a national prevalence rate of 8% compared to about 13.5% in the general population. Here in Colorado, we see a rate of about 10.2% among Asian Americans compared to the general population rate of just over 14%. So we may be pretty quick to say that, quote unquote, Asian Americans are not experiencing a tobacco use or cessation disparity. But Asian American is probably the wrong subdivision. The term Asian American is an extremely broad category that includes Indian Americans, Chinese Americans, Pacific Islanders, among many other groups. And each of these nation states have a different historical experience with tobacco as an agricultural, imported, or manufactured commodity. Each of these nations exhibits different prevalence rates. And just as in America, these relationships have changed over time. These differences are observed in different prevalence rates and use patterns between culturally distinct groups. And these correlations are not necessarily linear because they're not dependent exclusively on the relationships individuals had with tobacco in those countries, but between those individuals and the culture of America that they have historically and continue to encounter. And of course, I am actively, as I'm speaking, doing the diversity of this group a disservice because I'm implying a greater connection to tobacco in those historical contexts without even mentioning that, like Latinx, many Asian Americans can date their status as fully immersed Americans for over 150 years or more, which beats my own grandparents by a century. You've heard the phrase that we can't miss the forest for the trees, and some people will correct that and say that we need to make sure that we don't miss the trees for the forest. But this section, what I want you to carry away from here is that we need to make sure that when we think we're looking at trees, we're not just looking at smaller forests, okay? What is the rate of smoking among Southeast Asian Americans in Colorado, or among the Vietnamese in Colorado, or the Hmong? And I don't know the answers to those questions. I don't have that data. And that's a point I'm going to return to maybe in a few slides. The next piece of advice in working with Asian Americans is to recognize that there may be cultural inputs that keep the smoking prevalence rate lower in certain demographics. Maybe I shouldn't say not advice, but maybe lessons, is that there may be certain, these cultural inputs keep the smoking prevalence rates lower, but those same social pressures that keep prevalence rates low can also be shame-inducing, stigmatizing, even traumatizing for those individuals who nevertheless have experimented with tobacco and found quitting difficult. Which is to say that norms can be protective for some, but harmful for others. These negative normative attitudes can be quite severe, and actually they can keep stress levels really high, while also diminishing the scale of social supports that many people benefit from on a cessation journey. To say that maybe a little bit easier, shame around smoking can cause the stress that prevents cessation or causes relapse. One commonality we see across Asian American groups is a higher proportion of light or infrequent smokers, which I mentioned at the beginning of today's webinar. As I mentioned too, at that time, light smoking is often given lower priority in the treatment setting because in the technical language of the scientific literature, quote, the harms of smoking saturate early. Or to say it more simply, even one cigarette a day can increase the risk of premature disease and death. In fact, the first cigarette of the day does the most damage of any cigarette of the day. The second does the worst, the third more than the fourth more than the fifth, and so on. At BHWP, we often analogize this, up a little dramatically and a lot morbidly, as getting shot through the heart. your chances of living through the first bullet are pretty small already. If you get shot a second time, your odds do go down, but not as much as they did after the first one. When people smoke fewer cigarettes or smoke less frequently, the perception is that one, they're not dependent, or that their chance of dependence is lower, or two, that they're doing something healthier than the alternative. And both of these might cause providers to not screen for tobacco use or advise smokers to quit, at least nationally. And that is, in fact, what we see, which of course leads us to the next bullet. And once again, we see that systems that tighten up their screening and advising practices in order to capture disproportionately ignored groups are going to reduce disparities in screening and advice for that group, while also benefiting the general population as well. So the next group I want to talk about are African Americans. Now, this group, as I mentioned in the last webinar, does not have a use disparity when we look at the national figure, the aggregate national figure, or at least it isn't obvious. The general population, the white population, and the Black population are all within fractions of a point of one another. However, as I mentioned in that same webinar, we do see disparities when we look at both age and the sex of smokers, splits that drive older African Americans and male African Americans above their counterparts in the general population. And then, of course, I have to emphasize that in Colorado, we not only see that the gap between Black Coloradans and the general population is large, about a 12-point gap, nearly twice as many smokers in that category, but that gap is getting wider over time. So I do encourage everyone to consider prioritizing outreach and action in and for your local African American communities. Some things that we might consider, or some things that we might encourage our providers to do, is to know about and to communicate the uses for and the dangers of menthol. This is because most menthol users are African American, and most African Americans that smoke use menthol. So this knowledge is disproportionately salient in this community. And a history of how menthol was promoted in the African American community in a deliberate attempt to cultivate dependency may inspire some individuals to quit. In general, a closer look at specific advertising strategies and how they have been weaponized against Black communities can serve to inspire quit attempts and inoculate against the persuasive effects of future advertisements. Our tobacco cessation practitioners also need to be using strength-based and trauma-informed styles. Once again, we know that smokers in the contemporary context in the population at large are disproportionately more likely to have suffered childhood trauma, and individuals who experience childhood traumas are more likely to smoke. So this is another situation where when systems accommodate the needs of populations specifically targeted by the tobacco industry, there are always benefits that spill over to the general population. And we need to understand that the tobacco industry's main advertising strategy is to find vulnerabilities and sell not self-efficacy, resilience, intelligence, or creativity or love as a solution, but cigarettes. And this serves to disempower the targets of those ads, and in disempowering them, often re-traumatize them. Therapeutic modalities work in part by actively not re-traumatizing and also in helping the individual restore their own power. Finally, we need to be looking at materials that are written with the audience in mind. And of course, we always point to Pathways to Freedom as just one example here. I do highly recommend that if you have not already done so, engaging with and supporting the work of the Colorado Black Health Collaborative, and also reading the Health Justice and Tobacco Control Guide pictured on the right. I added that guide as a resource to the STEP newsletter. If you're looking to find it, you can also just use a Google search. I added there a couple months ago, and I seriously cannot recommend it enough. Next, I want to take a brief look at treatment considerations for the Latinx or Latinae community. I prefer the latter term, but I know the former is a little bit more common right now. Historically, this group has been called Hispanic or Latino, and it often shows up as Hispanic/Latino on census forms. In short, we're talking about those individuals who trace their culture, history, heritage to one of the roughly 24 countries in North, Central, and South America where Spanish is the primary or official language, and also Puerto Rico. We are not normally with these labels considering those from Spain, although individuals who do trace their history or ancestry to Spain and who still see Spanish in the home are often included in this group. Or in a state like Colorado, you have folks here who do trace their ancestry all the way back to the conquistador generations, and they also get tied into the Latinx community. When the emphasis is on Latino, which literally refers to Latin, then we sometimes are considering those countries where French or some version of French is spoken, like French Guiana or Haiti. or where Portuguese is spoken, as it is in Brazil. Every so often, we are speaking of the entire non-English speaking, quote unquote, New World, which would then extend our scope across the entire Caribbean. And I know all of that sounds really muddled and very confusing, and I actually hope it does, because like Asian American, this is a category of convenience. The substantive material, the things that matter in regard to tobacco use lies in the details. And I went into this in more detail in the last webinar, but this is as a reminder, it's worth peering past that top level demographic, past that phrase or that word Latinx, Latinae, and go down into the specific characteristics of the Latinx community in your area that you want to work with. Are you thinking of reaching out to 0th or 1st generation immigrants, the ones most likely to speak Spanish at home? Or are you thinking of reaching out to 2nd, 3rd, or 17th generation Latinx, those that primarily speak English at home and may in fact trace their ancestry back before English was even spoken in Colorado? They may have more access to care and may be more trusting of the medical system, but they're also more likely to smoke. As with all groups, we want to make sure that our materials are linguistically appropriate, not just in terms of language, which is obviously important here, but also in terms of literacy levels. We do encourage the use of promotores. Promotores, for those who do not know, are lay health workers who live in Latinx communities, are Latinx or Latina themselves, and are considered to be trusted leaders or experts on health-related matters. Promotores are often working at health fairs, administering diabetes screens, leading local exercise classes, and obviously screening for tobacco use and making referrals. Evidence for the effectiveness of promotores is mixed in the literature, but I consider the use of promotores to be at worst a cannot hurt, might help situation. That is, using promotores doesn't cause worse outcomes. It doesn't cause people to avoid seeking care. And in some cases, they obviously help. And even if they don't increase engagement with the health sector in the short run, it seems obvious to me that systems that use or partner with promotor programs are just going to be more trusted. And if those systems are persistent, they will become more capacious, more effective, and more trustworthy over time. And then finally, we do need to consider extra education around the safety of seeking services and the safety and effectiveness of nicotine replacement therapy, bupropion, and varenicline. So before diving into this slide, the low-income slide, I want to point out that one group I'm not talking about today is the behavioral health population. The reason, very briefly, is that group is where most of my work and trainings are focused. PHWP has dozens and dozens of videos on a variety of topics within that domain. Also, my colleague Derek and I have been hard at work working on a 3-part webinar series on that topic that we just finished earlier this month. So if that topic does interest you, you can definitely reach out and talk about it in the Q&A, but I encourage you to check out those webinars also, because I think that you'll find them very practically useful. I bring it up on this slide because mental illness and substance abuse is a cross-cutting, multiplicative risk, meaning that both conditions occur at higher rates in many of our other subpopulations. And when we look at, say, for example, Latinx with a mental illness or Asian Americans with a substance use disorder, we also see disproportionately higher rates of smoking. And that's also true with income status. Across the board, no matter which demographic you're looking at, no matter how big or small it is, if you add an income dimension, you will see higher tobacco use rates in that lower income division. And in almost all situations, systems that are better equipped to meet the needs of their low income clients, patients, are better equipped to meet the needs of all of their clients. So once again, we see the importance of moving screening and advice to quit to universality. While we know that low-income individuals are less likely to pay out of pocket for nicotine replacement therapy, other drugs, we know that that's actually true across the board. When large employer-based insurance plans add cessation coverage, the use of pharmacotherapy goes up. And I know that sounds really obvious, but it's also important and true. So organizations who are prepared to communicate what cessation benefits are available and how to activate them, then all groups benefit. And those who are disproportionately less likely to access such resources due to cost will benefit more than those groups who already avail themselves to some degree of that resource. I do want to pause here to clarify why I keep pointing out that benefits to these selected groups have spillover effects to other groups. Too often in discussions of disparities, those of us that advocate for reform are accused of focusing all of our attention and resources to marginalized groups and thus leaving the majority to wither on the vine. And this just simply couldn't be further from the truth. I've always thought about tailoring systems toward the marginal or the most difficult cases in terms of the OXO effect, OXXO. According to the lore or legend, the OXO company set out to make a potato peeler for individuals with arthritis. And this meant a fatter handle with an extra thick no-slip grip. And the end result was a product that everyone liked better. Now, sure, I, for example, had a regular cheapo potato peeler and could peel my potatoes just fine with it. So my quality of life only improved marginally with the introduction of the OXO peeler. However, the person with arthritis who could not peel potatoes at all before benefited a lot more, right? To talk about the OXO effect in more serious terminology, we need to understand that while systemic racism disproportionately delivers negative impacts to Black, Indigenous, and people of color, and disproportionately delivers benefits to white populations, the fact is that systemic racism hurts all of us. And you can call me a cynic if you want to, but I think that some people are fairly self-interested. And if you can't convince them that they're being harmed by the status quo, or that they'll be helped with changes to it, they may not fight for those changes. I think that we need to be aware too that politicians and budget analysts and program managers are going to consider the cost-benefit analysis function for a really long time and maybe forever. And so we need to figure out a system, a way of pointing out, I think that disproportionate benefits can close disparities while still improving conditions for everybody and not by leaving anyone out of those benefits. Or as Heather McGee put it, quote, "The ledger of racial harms is nowhere near balanced, but considering how we're all harmed by such injustices, quote, may bring more people's eyes and hearts to the cause in redressing them." Anyway, it's a bit of a digression, but I think an important one, and hopefully explains the tack I have taken today. So our final priority population is the LGBTQIA plus population, or populations. Here we emphasize the trustworthiness of the sites themselves. I'm sorry, I see I had a chat in there. I wanted to. So our final population day is the populations that are under the banner of LGBTQIA, and we are focusing on the trustworthiness of sites and making sure that sites know how to affirm care and also advertise that they affirm care. So care sites and providers should be looking for opportunities to make sure that their sites are seen as safe and affirming, while also, and I hope, obviously, making sure that their sites are committed to acting in that way. One way to do that is to ensure that providers are educated on community and individual level barriers, that they are comfortable and fluent in talking about those issues with their clients, and that programs and systems can design outreach strategies that, when possible, seek to overcome those barriers. As in most other areas, using interventions that are designed by and aimed at specific groups can help make safe spaces and increase that trust. So as I mentioned in the last webinar on this topic, this is a group that has been sought out by the tobacco companies. And so smoking is more common, and being an ex-smoker rarer. So sites should be on the lookout for individuals who can be empowered to become cessation champions. Or in other ways, in any way, really, trying to elevate LGBTQIA voices. Sites can also use the Gay and Lesbian Medical Association to identify and refer to welcoming providers, and or use online resources that do speak to the LGBTQ experience. So we're going to be transitioning now into the next thing, and I wanted to use this slide, building partnerships, as my transition slide, because really what we're asking of our providers when we're saying become culturally competent is the same thing that we're asking of our public health staff around the state when we ask them to reach out to sites that they may not be comfortable with, right? So I want you to kind of hear the next bit of thoughts in both ways. Like, am I talking to providers, or am I talking to public health? Am I talking about building partnerships with clients? I'm talking about building partnerships with sites in your neighborhood, health neighborhood. The process of engaged partnerships, right? It's a process, not an event. trust can take minutes or months to establish. And while you may only have a few calls with a potential partner, it's good to take the perspective that you're either starting or helping someone to continue engagement in the tobacco cessation space. There can be a delicate balance between providing support while encouraging people to set goals and act. The use of collaborative language is often just the support people need, right? Knowing that you are available to help them helps them feel like you're a real partner with them. When collaborating with others, it is important to understand that the person's motivation, what is the person's motivation? Why do they want to change? Show interest in their concerns, values, and motivations. It's also important to listen to the individual, sharpen your listening skills. It's often not what people say that's most informative. It's the specific choice of words, their cadence and tone that will tell you what they're really saying. When we seek to engage a new partner, we're often a little too eager to share our solution to the problems we think they have. And I saw this when I worked in a community behavioral health organization, and I see it now in this collaborative tobacco space. Your mileage may vary, of course. Perhaps you are a native partnership developer, fluent in the ways of identifying shared missions and communicating your value. I did not come at this naturally. So from here, I really want to, in the simplest way possible, define the goals of health systems change and a general approach to engaging with partners. But throughout, I want you to keep at the top of your minds that I'm less interested in the end result and a lot more interested in the partnerships themselves. The partnership itself is the end result I think that we should be focusing on. There's always room to improve a relationship. There's always a better version of a current tobacco cessation program. But to improve a relationship, you have to have a relationship. To make a program better, you first have to have a program. Okay, so what do I mean, or what do we mean? What does the world mean when we say facilitating health systems change, as the CDC calls it, in that document that I mentioned at the very beginning of the webinar? Personally, I think that can be an intimidating phrase, especially if you're new to tobacco control or if you're new to public health, and even more so if you're new to the professional world altogether and maybe don't have a lot of experience with quote unquote systems, let alone how to quote unquote facilitate changing them. In recent years, we here at BHWP and at the STEP program have defaulted to a different phrase, and we call it building a person-centered tobacco cessation health neighborhood, which is a little bit long-winded, but I do think it captures the idea a little bit better of what we're actually doing. But the danger of either of these phrases is they don't really explain the work. So I'm gonna try to be extremely simple about what we want, and what we want is to make sure that what we want is to make sure that individuals are universally screened for tobacco use. And if they screen positive, that those individuals who screen positive are connected to an evidence-based intervention that meets the needs of their level of dependence and their individual preferences. That's the end result, right? Connect tobacco users to evidence-based treatment. And there are several interventions that have a strong, consistent, and robust evidence base for use in various populations, in various treatment settings, and with a variety of providers. And these interventions have all been given a grade of A from the United States Preventative Services Task Force. And that means they all qualify for reimbursement from Affordable Care Act compliant insurance plans. And those are the interventions that we talked about earlier. They are on the previous slide, or in an earlier slide in green, right? Ideally, we want this screening and connection to be embedded within a formalized structure that itself can be standardized, measured, and then therefore improved over time. Now, the way we normally talk about this formalized, standardized process is we call it the 5 A's, and they're pictured at the top of the slide. We're going to use the 5 A's to appropriately direct people into the best care for them, right? So the 5 A's, again, if you're new, this is a terminology that you should be familiarizing yourself with, and it stands for ask, advise, assess, assist, and arrange. So when I teach the 5 A's, I teach them not in terms of the cutesy acronym here. I'm a kind of an enemy of cutesy acronyms. I talk about their functions, right? And when we talk about what the 5 A's does, this allows us to ask the right questions of our potential partners so that we can align their systems with this structure. And we don't always have to talk about the 5 A's. We can talk about what we call ask, advise, and connect. And sometimes it's called ask, advise, and refer. And the key difference in the terminology between ask, advise, and refer, which is the standard old school way of talking about it, and ask, advise, connect, is that we are ensuring that in the AAC version, we're ensuring that the referral takes the tobacco user's needs and preferences into consideration. And in an ideal situation, it utilizes a warm handoff to the referral site. And the emphasis is making the right referral to the right patient at the right time and in the right way. So we have a goal to make sure that all tobacco users are connected to the right evidence-based intervention for them. And our strategy is that systems that those tobacco users engage with have the capacity to screen for tobacco use, assess their level of need, and then make those connections. So how do those systems gain that capacity? Well, that's where public health comes in. Public health programs have the expertise and resources to train their staff to explore current structures, to make recommendations for tobacco-focused adjustments to current processes, to provide those resources that supplement and sustain those new processes, and to encourage and aid in setting proper benchmarks for evaluation. And if you're right now thinking, I do not have those skills, that knowledge, or that expertise, that's okay. You have a bevy of resources through Tobacco Free CO, your STEP program officers, and all statewide TA providers, including me and the rest of the BHWP team. Between individual TA, learning community calls, new and continuing training, archived webinars, we can get you whatever you need in terms of skills and knowledge. The hard part, and the part that's going to be mostly up to you, is actually building the partnerships themselves. And I should say, I work in a lot of states. I work with other state tobacco programs. And in some of those arrangements, I work directly with the counties, just as I do here in Colorado. And I have to say, this is a unique strength of the Colorado system. That is that you have a lot of autonomy in determining who you're going to work with and how you're going to work with them. It does mean that you have to take on some leadership responsibilities, though. You have to identify which partners you want to work with to achieve your program's goals. And you may have to shop around for partners that are willing to work with you. And as a result of who you find there, you may have to move or restrict your goals based off your partner's particular goals or strategies. In short, and to keep it as simple as I can, I would just start by listing all the organizations in your jurisdiction that engages with any or all of your priority populations. This could be other government entities, libraries, social services nonprofits, advocacy groups, professional organizations like your Chamber of Commerce, schools, sports leagues, and on and on. And of course, we can't leave behind all of our medical, behavioral health, or healthcare adjacent organizations like hospitals, clinics, pharmacies, dentists' offices, etc. After you list them, you need to develop an outreach strategy, and you may divide your outreach strategy between those entities that you simply want to introduce yourself to and those others that you actively want to recruit. And after you've identified who you can work with and who you want to work with, then you need to figure out how to sell yourself to them. And to do that, you need to figure out what their mission is and how tobacco cessation helps them fulfill that mission, their mission. And once you do that, just keep being there. I changed this slide yesterday because I was on a call earlier this week where somebody said that you have to be pleasantly persistent. I'm like, oh man, I'm stealing that. And so here it is, effectively stolen and repurposed. You have to be pleasantly persistent. Let them know that you're here. And more importantly, let them know that your program is here. That way, if you move on to a different site or somebody else takes on the face fronting, the individual fronting role, then they still know, they see that continuity from program officer to program officer. So, once you've listed out all your potential partners, how do you start the process of prioritizing them into those who you want to introduce yourself to and who you want to actively court? Well, the characteristics on this slide are the ones I initially think of. You may have your own set of preferences. I just would come up with some system. I'm looking for those organizations that I think are going to be willing to engage with me in an active collaboration and compromise process, and that I think already are or can reasonably be persuaded to actively and independently engage in tobacco cessation. Which is to say that their ongoing participation in tobacco cessation programming cannot depend on me giving them a call every 2 or 3 days, right? They have to want to do it on their own. And that is something about their mission, right? But that's what I have to think about. Something about their mission, their values is already aligned with tobacco cessation goals. And I think a really good example here is working with drug courts. Drug courts are theoretically, at least, committed to long-term abstinence of their program participants from alcohol or other drugs. And I know that tobacco cessation increases the chances of long-term abstinence from other drugs. So my tobacco cessation goal serves their alcohol and other drug abstinence goal. So we used to talk about this in terms of strategic or mission alignment, but that isn't really accurate. In this case, my strategic goal, tobacco cessation, is one of their tactics to achieve their goal, which is alcohol and drug abstinence, alcohol and other drug abstinence. So one important factor here, and I've already alluded to this, is that you don't have to limit yourself to just a single partner or a type of partner or any individual or site. Which is that any individual site can be a partner in a health neighborhood. Anyone can be trained to screen for tobacco use. Anyone can refer to an evidence-based provider. The only requirement is that the individual or site is willing to partner with you. And by partner, I mean that they are willing to meet with you regularly, receive resources from you, including training, and ideally work with you to improve those services over time so as to optimize the tobacco cessation outcome that each site is capable of. So I say my final, but maybe it's my second to final piece of advice as you start to reach out to partners is just to relax, right? You're the expert. I once worked in a mailroom. I was the mailroom supervisor, and I remember quite a few instances where people would walk down to the office, the mailroom, and hand us packages and say something like, "Can you take this package and do whatever it is you do to make it get to that address?" Literally, I mean, that's almost a quote. And listen, here's what a mailroom does. We put the address on the package and we pay for its delivery, exactly like you do when you mail a letter at home. There's this tendency to think that what other people are doing is mysterious or even magical. And I've been in a lot of the systems I've listed today, either as an employee of them or as a recipient of their services or as a consultant here from BHWP. And there's nothing magical going on anywhere. People are brought into systems, their needs are assessed in some way, and then services are rendered to meet those needs. That's it. You don't need to be an expert in every system. They're the experts in their system. You are the expert in tobacco cessation and the supportive processes and resources. All you have to do is engage in a thoughtful conversation with those partners in search of spaces and times where you can work together to achieve common goals, right? So this is my favorite advice, and this is my final advice. So Tom Wolfe was a reporter back in the 60s and 70s, and he got his start interviewing fringe or outsider groups. And he said that when he started out, he used to dress and act like his idea of the people that were the subjects of his stories. And his idea there was pretty obvious, right? He wanted to be considered a trusted and knowledgeable person so that they would respect him and therefore be more forthcoming in their comments. And what he found out to be the case was the opposite. When he dressed and acted like his subjects, if he was unsuccessful, then he was perceived as less trustworthy, less worthy of respect, because he was a poser, right? He was faking it. And if he was successful, then he couldn't ask the questions that he needed to get answered because he was broadcasting the image of a person who should already know the answers to those questions. So what Tom Wolfe did is what you see on this slide. He adopted this extremely extravagant white suit, hat, and cane combination as his uniform. He said that when he did that, he was an alien wherever he went, and he was free to ask whatever questions he needed to ask. And that's the advice that I want to give to you. As you go from system to system, most are from site to site, from business to business, from club to club. Most of the time, you're going to be an alien there. That's okay. Don't be afraid to be an alien. Being an alien means you're free to ask whatever questions you need to get answers to be a good partner. My path to this advice was long. I tend to see similarities between systems, but the way any program looks inside is going to be determined by that system's unique characteristics. As such, you simply cannot be afraid to ask any and all questions, including ones you think you're supposed to know the answers to. No one wants to be an expert. No one wants you, that is, to be an expert in their system, and they're going to be put off if they catch you pretending to be one. Anyway. DHWP has a ton of researchers on how systems change. The three pictured here are the ones I consider the three-legged stool of this work. And this is where I would point anybody who's just beginning this work. There are other resources out there. And once you have more specific needs, definitely reach out to me and I can connect you to those resources. But these are the ones that I would definitely point you to start with. And that concludes my remarks for the day. If you have any questions, please put them in the chat, raise your hand, unmute your line, whatever it takes. I'm happy to field any questions. And I know that Valerie's already gone, but yes, this will be recorded, archived, and put on Tobacco Free CO. I'll be sharing a link out in advance of any edits or whatever necessary to get it onto Tobacco Free CO. All right, everyone. Thank you for your time today. If you do have any questions, please email or call anytime. Otherwise, I'll catch you all later. You're free to sign off.